Hi, it's Christina Weng from Baylor College of Medicine, and I'd like to welcome you to the Retina TLDR, where we tackle the most topical issues in the retina space with leading experts in the field. It's my pleasure to welcome here today a colleague and dear friend, Dr. Frank Brodie, who's an assistant professor at UCSF and the medical director of Science Corporation. Dr. Brodie always has his hands in some really cool stuff, so we're very excited to have him here as a guest today to tell us about a promising device that may allow blind patients with geographic atrophy regain visual function. Welcome, Frank. Thanks so much for being here today.
Oh, thanks so much for having me, Christina. It's really a pleasure.
Absolutely. Well, we're looking forward to learning about PRIMA today, but if I may, let me take a moment to explain the catalyst behind the series. The world in 2026 moves faster than ever, and last year I learned that the average attention span has shrunk to a mere 47 seconds. So even though I encourage the audience to tune in for the entire conversation, we start every interview with a TLDR. So Frank, what's your TLDR?
So the PRIMA implant is a subretinal photovoltaic implant used to restore vision in patients with geographic atrophy. In a study that was just published in the New England Journal of Medicine, it showed that 80% of patients who received the PRIMA implant were able to regain the ability to read letters, numbers, and meaningfully improve their vision.
Super exciting. Can't wait to dive in. Tell us a little bit more about the device and exactly how this photovoltaic device works.
So you can think about it almost as artificial photoreceptors. If you think about solar panels, they do light into electricity, and that's also what our device does. It responds to infrared light, so the patient will wear some glasses that capture the world around them, send that as infrared pulses onto the chip, which is subretinal. That then converts that to electricity, which triggers the bipolar cells overlying it. In a way, you've kind of restored the visual cascade in a GA lesion. And that's what we saw in the clinical trial. And these were patients that were 23/20 or worse, so very, very low vision. And these patients regained the ability to read letters, numbers. The average improvement was 5 lines of vision in those patients. So we were very excited about the result.
Well, that type of visual improvement could be incredibly meaningful. And I imagine, Frank, that there was variability in the patient response amongst the 32 patients with 12-month data in the PRIMAvera study. Tell us, were there any characteristics that predicted greater improvement?
Yeah, we looked really closely at this because you're absolutely right. There was a heterogeneous population of results. Even though the average was very good, it was distributed. The main thing was the rehabilitation program. The patients that participated in the rehabilitation, used the device regularly, really did much better. We think both that's because they learn how to use the device more fluidly, but also there's some neuroadaptation that occurs. The other big predictor that my wife said she knew already was that women somehow did a lot better than men.
No surprise there.
None.
Yeah, so I think that's really important for the audience to know that it's not just the implant itself, but it's really coupled with that learning process, that training that needs to happen afterwards. So I'm glad you pointed that out. Now, Frank, in addition to being an entrepreneur, you're very well respected as a world-class surgeon. And I'm curious, what is the surgery like for the Prima implant? Are there any technically difficult steps on the learning curve, and what types of complications should we be looking out for?
Cases started with a vitrectomy. Then they induced a subretinal bleb using BSS, created a retinotomy. Now, this was a 2 by 2 millimeter chip. So the retinotomy was about 2.5 to 3 millimeters wide to make space for an injector. Now, a sclerotomy was created, a 3 millimeter sclerotomy. The implant was then injected through the sclera, through the retinotomy into the subretinal space. In a lot of these patients, the bleb didn't dissect out all the way into the GA lesion. So in some of those patients, they did have to blunt dissect prior to injecting the implants. In some patients, they didn't. After the retinal implant was placed underneath the retina, there was PFC used to flatten the retina. They went to air, and then either gas or oil was the tamponade used. The complications we saw, at least in the trial, were primarily having to do with the surgery, doing subretinal surgery. There was a little bit of subretinal hemorrhage, breaks, things that you would expect. One thing that was learned during the surgery is if the fovea is very thin, less than 50 microns, you do want to avoid the fovea as you run a greater risk of macular hole. In some patients, a macular hole was meaningful, and some it wasn't. There was 4 macular holes total in the study, but in some patients, they did have to move the implant away from the hole. Overall, it was really just having to do with surgery. When we look past the first 3 months, there was only very rare complications. And those were things like the development of CNV, which we expect to see in patients with GA anyways, to some degree.
It's a little bit reminiscent of the Argus 2, which some of the listeners might be familiar with, which is another visual prosthesis device. I'm curious, how does the Prima differ from Argus 2?
The key difference is that it is subretinal as opposed to epiretinal. And clinically, that really matters because now you can take advantage of all the processing those bipolar cells do. If we remember, there's 100 million photoreceptors, 10 million bipolar cells, and 1 million ganglion cells. And so there's a lot of compression of information that goes when you're going from photoreceptors to bipolars to ganglion cells. And by nature of its epiretinal location, the Argus wasn't able to take advantage of all that processing power of the retina. Because this is a subretinal implant, really just replacing the photoreceptors, we get to take advantage of that. And I think that's why we see such markedly different visual results. We really see form vision. The second big difference is it's totally wireless. Because it's a photovoltaic implant, the visual information itself is actually powering the chip. We don't need any wires. We don't have anything going outside the eye. You don't have any batteries. It's really just powered itself by the light. And that makes, I think, a safer and cleaner surgery.
And I know that steps are being taken with the regulatory agencies in the EU. What's the plan for bringing this device to the United States?
Well, we're really eager to bring it to the US. We're working right now with the FDA to figure out the best path for that, whether it's through an HDE approval, similar to what the Argus had, or through a full PMA without restriction. We're also very interested in Stargardt's disease. In some senses, you can think of that as an inherited form of geographic atrophy. So also looking at some Stargardt's trial in the US as well.
That would be phenomenal. And Frank, where can viewers go to learn more about PRIMA?
So the best place is on the Science Corporation website. It's going to be science.xyz, and you'll find a whole PRIMA section there. Patients, or if you have loved ones that are interested, we have a patient registry through Science Corporation. That's patients.science.xyz.
Fantastic. And we'll make sure we leave those links below for the viewers to access and on their own time. The last question is really just off the cuff, Frank, not related to the PRIMA, but somewhat related. I mean, you've been an incredible innovator in our space. And I also want to highlight the work you're leading with Longbridge Medical in developing what essentially is an artificial capsule device for secondary IOL implantation, some of my favorite surgeries. I want to ask that and so many other things. And I first actually heard about your work with Longbridge Medical from our mutual friend, Jean Dewan, when you presented this at Veil Vitrectomy last year. But you're involved with so many different technologies and innovations. How did you catch the innovation bug?
Oh, thanks, Christina. That's very nice things to say. It was really been mentorship. My uncle is also a retina surgeon, Dan Schwartz, and he developed the light adjustable lens. And so seeing him go through that process and the impact you can make, I think we're very fortunate as physicians as we get a front row seat to the problems patients and surgeons face. And we have an ability to change that and develop new things to improve the lives of patients and surgeons. And it's just where I really enjoy spending my time.
That's a fact I did not know about you after knowing you for so many years. So clearly it's in the lineage.
Can't fight genetics.
Absolutely. Well, so exciting to learn more about the PRIMA system, and I'm really hopeful it's going to continue its forward progress. Kudos again on all your terrific work, Frank, and thank you for being here today.
Thank you so much, Christina. It's been a pleasure.
Well, we've just kicked off season 2 of the Retina TLDR, and we'd welcome your feedback, so please reach out with any through the contact included here. In the meantime, I'm your host, Christina Weng, and we'll catch you next time on the Retina TLDR.